Welcome back. In today's video, I got something really special for you. We're going to do another video for another EOR. In this case, we're going to do OBGYN with 120 EOR pens and penalty style questions. These are the same type of questions you will encounter during your exam. And for all of us that are going through our clinical rotation, we know how crunched the time is. And one of the things that I found when I was in school is a lack of these style of questions, and I actually failed my OBGYN exam the first time. That's the only ER exam I failed. And I failed it because I focused on studying too much from several different resources and I did not practice enough questions. And 120 questions in 2 hours can be a lot. Another thing that really helped me was developing a good test taking strategy. And for long stem questions, I would read the last sentence first, like in this case, which of the following is the next best step in management? Go over the answers and then start reading the stem. With that, I would always focus on what the question is asking, what the answers are. Then within a stem, I'll try to find my answer. And most of the times, I'll have the answer before I even get to the final question. So, a 28-year-old woman reports a sudden change in her menstrual cycles, now having heavy bleeding the last 8 to 9 days with clots. She denies pregnancy. Which of the following is the next best step? Reassurance, start OCPs, check hemoglobin and TSH, and endometrial biopsy. And the answer is we should always check hemoglobin and TSH in any lady presenting with abnormal urine bleeding. That's likely to rule out thyroid dysfunction and evaluate for anemia from blood loss. So as soon as you see clots, you should have connected that with hemoglobin and abnormal urine bleeding with needing to rule out TSH. Reassurance is premature without ruling out the cause. OCPs might be helpful, but they would not help us understand the etiology. And an endometrial biopsy is not a first line in a young woman with no risk factors. So the giveaway in this question was that she's having heavy bleeding plus clots. So we should always check for anemia and a thyroid first before any other treatment options are given. Number 2. A 22-year-old woman presents with a secondary amenorrhea for 6 months. She has low FSH and LH, normal prolactin, and a history of intense exercise and weight loss. What is the most likely diagnosis? Premature ovarian failure, hypothalamic amenorrhea, polycystic ovarian syndrome, and hyperprolactinemia. Well, we can right away rule out hyperprolactinemia as she's presenting with normal prolactin, and we should focus on hypothalamic amenorrhea because of other signs that she's presenting besides the labs, such as weight loss and intense exercise, such as in athletes and so forth. And that should lead us to hypothalamic amenorrhea because all that exercise, weight loss, and stress will suppress the GnRH secretion, causing the low FSH and LH, leading to amenorrhea. Premature ovarian failure will show high FSH and LH. PCOS usually presents with a normal or elevated LH and irregular cycles. So PCOS, you should think about irregular cycles. This is a lady that didn't have her period for 6 months. And hyperprolactinemia, as we already discussed, will have high prolactin. So stress plus exercise shuts down the GnRH, leading to the hypothalamic amenorrhea. So I can hope you guys can see how these questions can be very helpful as you're preparing for your EOR. What is the next best step? Start OCPs, reassurance, endometrial biopsy, start NSAIDs. 47-year-old woman presents with unpredictable menstrual bleeding for 8 months. Her BMI is 33, and she has hypertension. Beta HCG is negative, and ultrasound shows thickened endometrium. What is the next best step? Well, it should be endometrial biopsy because this lady is over the age of 45 with some risk factors such as obesity and hypertension, and she needs a biopsy to exclude hyperplasia. So when it comes to the A, we should never treat hormonally without ruling the malignancy. Observation is unsafe given her age and findings that she presents, and NSAIDs are helpful for symptoms, but they're not diagnostic. So over 45 plus thick lining should make you pick biopsy first. What is the next best step in management? Reassurance and continue NSAIDs, diagnostic laparoscopy, endometrial biopsy, and start antidepressants. 25-year-old woman presents with a painful menses, not relieved by NSAIDs. or OCPs. She denies STIs. Pelvic ultrasound is normal. What is the next best step in management? There should be diagnostic laparoscopy. So, persistent pain, despite treatment that she has tried already, such as NSAID and OCPs, with normal imaging, suggests a secondary cause such as endometriosis. And to rule out endometriosis, we need to perform diagnostic laparoscopy. Reassurance in continuing NSAIDs. She already failed conservative therapy. Endometrial biopsy is not indicated without abnormal bleeding or age over 45. And for antidepressants, in her presentation, there was no evidence of depression, and pain is gynecological. So pain persists despite treatment. Time to scope the pelvis. Question number 5. What is the first line treatment? Combined OCPs only, NSAIDs daily, SSRIs, GnRH agonists. A 32-year-old woman has mood swings, anxiety, and breast tenderness only in the luteal phase of her cycles. She tracks symptoms for 3 months, which resolve with 2 days of menstruation. What is the first line treatment? Well, should be SSRI. So she reports mood swings, anxiety, reduced mood symptoms, and SSRIs can be given in luteal phase only to help treat these types of symptoms. OCPs are second line or adjuncts, and NSAIDs relieve physical symptoms, but they will not help with her mood. And GnRH agonists are reserved for refractory cases. All right, this is a good time to present to you PS Study Buddy's OBGYN EOR study book. This book will significantly help you improve your scores, help you study smarter, not harder. It will cover every topic from the OBGYN blueprint, and it comes with 120 mock style questions, just like the ones we have covered. I just wish I had a book like this when I was in school. I'll probably would score higher, would study less, and be able to spend more time with my family. So the book is on Amazon. Go ahead and check it out. I'll leave the link in the description below. Let's continue. Question number 6. Which of the following is the best initial recommendation? Combined OCPs, NSAIDs as needed, lifestyle modification, including exercise and dietary changes, and start antidepressants. A 25-year-old woman has cyclical bloating, breast tenderness, and mood swings before menstruation. She prefers to avoid medications. So that is a key question in it. If she prefers to avoid medication, which of the following is the best initial recommendation? So if she wants to avoid medications, then pretty much all of the other options are out, leading you to those lifestyle modifications to include exercise, which should help with her mood and dietary changes as well. So the first line treatment for mild to moderate PMS symptoms is lifestyle modifications. OCPs are used for more severe symptoms, and NSAIDs treat physical symptoms but not her mood, and start antidepressant is reserved for the severe symptoms or PMDD. So mild PMS, start with the lifestyle first. A 55-year-old woman with menopause reports recurrent urinary tract infection and painful intercourse. What treatment is most appropriate? Oral antibiotics, vaginal estrogen, systemic hormone replacement therapy, and NSAIDs. So this is a 55-year-old lady in menopause having some UTIs and painful intercourse, and this should be treated with vaginal estrogen. Vaginal estrogen will treat her atrophic vaginitis, which is causing her symptoms. So oral antibiotics will treat the infection, but not the underlying atrophy. And systemic HRT may help with the vaginal estrogen targets local symptoms with fewer risks. So C is out, and then NSAIDs do not relieve genitourinary symptoms. So local dryness and infection, vaginal estrogen. A 30-year-old woman has cervical warts on exam and a low-grade squamous intraepithelial lesion on a pap smear. What is appropriate management? Topical, oral antibiotics, acyclovir, or observation? Well, in this case, we should treat her warts with a topical uh, imiquimod or cryotherapy. So you can freeze them or treat them topically. So the warts and the low-grade lesions are treated with topical or ablative therapy. Antibiotics are ineffective against HPV, so are antivirals. Observation may be insufficient depending on a lesion's severity. So HPV warts respond to the topical or surgical treatment. So in a stem, you can see that she's having a low-grade lesion. She's also has warts. So when it comes to warts, you want to treat them with cryotherapy, and a lesion, so forth, we can pick, cryotherapy or topical if there was only one as an answer option. So antibiotics and antivirals will not help with HPV, and observation is insufficient. What is the best next step? Empiric treatment with ceftriaxone or doxycycline, start acyclovir or the HIV test only, prescribe metronidazole. A 30-year-old man has urethral discharge and dysuria. Gram stain shows gram-negative intracellular diplococci. What is the best next step? And for him, with the symptoms of gonorrhea, with urethral discharge and dysuria, and a gram stain showing gram-negative intracellular diplococci, you should be thinking of gonorrhea. And empiric treatment is with ceftriaxone and doxycycline. Immediate dual therapy is indicated. Antivirals will not be helpful here. So B is out. HIV testing is important, but does not replace the therapy or treatment. And D, prescribe metronidazole, while metronidazole is a treatment for trichomonas and BV, not for gonorrhea. So gram-negative diplococci, treat fast with ceftriaxone. A 22-year-old pregnant woman tests positive for gonorrhea. What is the next step? So they can make this stem much, much longer if they want to and give you a bunch of other fluff. But the key part is that this is a pregnant lady and tested positive for gonorrhea, and we should always treat this with intramuscular ceftriaxone. So IM ceftriaxone is a treatment choice for pregnant ladies with gonorrhea. It is safe and effective during pregnancy. Doxycycline is contraindicated in pregnancy. Untreated gonorrhea is a risk for neonatal infection, and azithromycin alone is insufficient. So, any pregnant lady with gonorrhea, you should be thinking intramuscular ceftriaxone. A 25-year-old man presents to urgent care with urethral discharge and dysuria. NAT is positive for chlamydia. What is the alternative treatment if azithromycin is contraindicated? Doxy, ceftriaxone, oral acyclovir, or metronidazole. Well, we already know that metronidazole is not gonna treat his chlamydia, so we're gonna be looking into doxycycline 100 milligrams twice daily for 7 days if he cannot take azithromycin. Doxycycline is alternative first-line treatment for chlamydia. Ceftriaxone treats gonorrhea, antivirals for herpes, and metronidazole is for trichomonas. Doxycycline works if azithromycin can't. So, chlamydia, you're going to be thinking azithromycin. If that is not treatment options for some reason, like in this presentation, then doxycycline is the next best thing. A 28-year-old pregnant woman is diagnosed with chlamydia. What is the safest treatment? Doxycycline, azithromycin, metronidazole, acyclovir. I've already kind of covered this in the previous question. So 20 or whatever age pregnant woman diagnosed with chlamydia, we should treat her with azithromycin. Azithromycin is safe in pregnancy. Doxycycline is contraindicated. Metronidazole is for BV and trichomonas, and acyclovir is for antiviral stuff such as herpes, not for chlamydia. Pregnant woman gets azithromycin for chlamydia. A 30-year-old man has recurrent genital herpes outbreaks. What is the best long-term management? No treatment needed, suppressive antiviral therapy with valcyclovir, daily antibiotics, surgical removal. Well, if you're thinking about a long-term treatment, then excuse me, suppressive antiviral therapy would be the best choice with valcyclovir. Daily antivirals reduce the recurrence frequency and viral shedding. No treatment would be not to treat, and the recurrence continues. Daily antibiotics do not affect viral infections, and surgical removal is not effective for HSV. A pregnant woman presents with a genital HSV lesion near term. What is the safest delivery method? Again, they can make this question much longer with much more fluff, but this is the lady with HSV lesion near term, and the safest delivery would be cesarean section. So the C-section reduces neonatal herpes risk if active lesion is present. So with vaginal delivery, it would be exposed to the baby. So it would be with the forceps delivery, and induced labor without cesarean section does not prevent transmission. So of all the presented options, C-section is the safest for a baby. So vaginal delivery risk neonatal transmission. Forceps increase the trauma risk, and induced without cesarean does not prevent transmission. Active genital HSV near delivery, C-section saves the baby. A 20-year-old woman presents with genital warts. What is the first line treatment? Oral antibiotics, topical, oral acyclovir, cryotherapy only. Well, in this presentation, we're going to go over the topical treatment because imiquimod is effective topical therapy for genital warts. Antibiotics will be ineffective, and so will the acyclovir because that's for HSV. Cryotherapy is also an option, but a topical therapy is the first line treatment. Warts respond well to the topical immune boosters. So, genital warts, if they give you only one option, I'll pick topical, and they may also say topical plus cryotherapy, in which case that would be the correct answer. Okay, let's keep going. You guys are doing great. A 30-year-old woman has a painful genital ulcer and tender swollen lymph nodes. She's treated with azithromycin. What else should be done? Test and treat sexual partners. No further action needed. Start antivirals. Prescribe antifungals. Well, this is a painful genital ulcer with tender swollen lymph nodes. So, this is a presentation of a chanceroid, and they should always have their partner treated as well. So test and treat sexual partner with any presentation of chanceroid. It will prevent reinfection and further spread. B is no further action needed. Well, reinfection common without partner treatment. Antivirals will be not useful for chanceroid, and antifungals are just not indicated here. So with any treatment for syphilis and all this chlamydia, we should always talk about treating the partners as well. A patient with lymphangioedema venerum, LGV, has flatulent buboes. That's a cool word, buboes. What is the best next step? Antibiotics, surgical drainage or aspiration plus antibiotics, observation, and antiviral therapy. Well, with LGV, we're going to talk about surgical drainage and aspiration plus antibiotics because this will help drain the bubo and it will help them with antibiotics. Antibiotics alone may not resolve the abscess, delay risk fistula and a chronic disease, and antivirals are not indicated. So LGV with flatulent abscess, drain it and give those patients antibiotics. What is the best initial management? Empiric antibiotics covering gonorrhea and chlamydia, immediate surgery, NSAIDs observation. A 22-year-old woman presents with lower abdominal pain, fever, and a maculopurulent cervical discharge. Pelvic exam reveals cervical motion tenderness. What is the best initial management? Well, with the cervical motion tenderness, fever, lower abdominal pain, this should make you think of pelvic inflammatory disease, and empiric antibiotics covering gonorrhea and chlamydia would be the treatment of choice. Prompt broad spectrum antibiotics prevents the complications. Surgery is reserved for abscess or failed medical therapy. NSAIDs alone are inadequate, and observation will risk the progression and infertility. So, fever, abdominal pain, cervical discharge, right there should make you think of antibiotics covering gonorrhea and chlamydia to help treat her pelvic inflammatory disease. A sexual active woman is diagnosed with PID. Which of the following is an important consulting point? No need to inform sexual partner. Abstain from sexual activity until treatment is complete. Only treat if symptoms worsen. PID does not affect fertility. Well, we should abstain from sexual activity until treatment is completed in pelvic inflammatory disease. Partner needs testing and treatments. Early treatment is crucial, and PID can cause infertility. Stop sex till PID clears. No sex until PID is clear. Which diagnostic test would definitely confirm the diagnosis? RPR, FDA, HIV, PCR. A 25-year-old woman presents with a diffuse, non itchy rash involving her palms and soles. She also complains of mild fever, sore throat, and generalized lymphadenopathy. She recalls a painless genital ulcer a few weeks ago that healed on its own. You suspect secondary syphilis and order laboratory tests. Which diagnostic test would definitely confirm the diagnosis? So this question is asking you basically which diagnostic test will diagnose the syphilis, and that would be FTA-ABS. This test is tropomonal test that confirms syphilis after a positive screening test. RPR is non-tropomonal screening test prone to false positives. HIV test is unrelated to the syphilis diagnosis, and the PCR for HSV detects herpes, not syphilis. So another way, if you're not sure of the answer, but you know what the treatments are or you know what the tests are, then you can go by a system of elimination. So HIV would be out because we're talking about syphilis here. PCR is for herpes, so that would be out. And RPR is non-trichomonal screening test, so that leaves us only with the FDA. Confirm syphilis with FDA after positive screening. A 22-year-old woman presents with a frothy, greenish vaginal discharge and vaginal itching. On speculum exam, the cervical appears erythematous with punctuate hemorrhages, strawberry cervix. Vaginal pH is 5.5, and motile organisms are seen on a wet mount microscopy. What is the appropriate treatment? Oral fluconazole, oral metronidazole, oral clindamycin, or oral acyclovir. Well, you can rule out acyclovir because this is not viral. This is going to be a presentation of trichomonas with that greenish, frothy discharge with a strawberry cervix and a pH of 5.5. So metronidazole will treat trichomonas. Fluconazole treats candida, yeast. Clindamycin treats the BB. A 22-year-old woman with frothy vaginal discharge and itchy tests negative on a wet mount microscopy. Her vaginal pH is 5.1. What is the best next diagnostic step? No further testing needed. Treat empirically for candidiasis. Perform NAT for Trichomonas vaginalis. Order serum PRP for syphilis. Prescribe metronidazole without further testing. Well, we should always perform NAT for Trichomonas vaginalis as she's having that frothy vaginal discharge and itching was negative. The itching test negative on a wet mount score. So a NAT is more sensitive than a wet mount and confirms the diagnosis of Trichomonas vaginalis. So if you have initial screening test that was negative or inconclusive on a wet mount, the next best thing is NAT. Candida usually presents with a normal pH and a thick discharge. Syphilis testing is unrelated to this presentation. Treating without confirmation risk inappropriate therapy. So giveaway, negative wet mount, NAT reveals hidden trick. So NAT reveals hidden trick. A 25-year-old woman with thin vaginal discharge and fishy odor is diagnosed with bacterial vaginosis. Which test helps confirm the diagnosis by detecting clue cells? Cough prep, wet mount, NAT for Cardinalaria vaginalis, and serum antibody test. So in this presentation, we're dealing with the BV. We want to be able to detect clue cells, and for that, we need wet mount microscopy. So wet mount identifies clue cells, diagnostic for BV. Cough prep is used to detect yeast and fishy odor, but not for clue cells. NAT is not routinely used for BV diagnosis, and no serum antibody test for BV. So wet mount microscopy looking for clue cells. A 60-year-old woman on aromatase inhibitors for breast cancer develops vaginal dryness and dyspareunia. What is the most likely cause? Infectious vaginitis, atrophic vaginitis due to the estrogen deficiency, vulvar lichen sclerosis, allergic reaction to medication. So she is taking medication for her breast cancer, which can cause that atrophic vaginitis due to the estrogen deficiency. So aromatase inhibitors, they will lower the estrogen, causing vaginal atrophy and these symptoms. Infectious vaginitis usually has discharge and itching. Lichen sclerosis presents with white plaques and itching, and an allergic reaction typically causes rash and erythema. So, atrophic vaginitis due to estrogen deficiency is seen in ladies taking breast cancer medication. A 58-year-old postmenopausal woman reports recurrent UTIs and vaginal irritation. Exam reveals pale, thin vaginal walls and vaginal pH of 6. What is the best next step? Prescribe antibiotics for UTI only, initiate topical vaginal estrogen therapy, order vaginal biopsy, advise increased hydration only. So, in her presentation, we should initiate topical vaginal estrogen therapy. So, she has UTIs, she has that vaginal irritation, pale, thin vaginal walls, and estrogen therapy improves the vaginal mucosa and reduces recurrent UTIs. Antibiotics alone don't address underlying mucosal atrophy. Biopsy is not indicated in this presentation, and hydration helps but will not fix her atrophic mucosa. So, recurrent UTI plus atrophic mucosa, those pale thin vaginal walls, we should think about treating that with estrogen therapy to fix both. A 35-year-old diabetic woman complains of recurrent vaginal itching and discharge despite multiple treatments. Which underlying condition should be evaluated? HIV, diabetes, syphilis, and chlamydia. Well, they kind of give it away in a question stem. Given that she's diabetic, when multiple treatments failed, we should check her diabetes. Diabetes is a major risk factor for recurrent candidiasis due to the high glucose level promoting fungal growth. So HIV, syphilis, and chlamydia will not have that presentation. A 30-year-old pregnant woman has intense vulvar itching and a thick white vaginal discharge. Which treatment is safest? Oral fluke, topical azoles, oral metronidazole, or oral doxycycline? Well, topical azole antifungals for candidiasis. So in this presentation, the topical azoles are safe in pregnancy. Oral fluconazole is generally avoided, especially in the first trimester. So another question could be if you wanted to treat with oral fluconazole, what would prevent you from doing that? And the answer would be like especially the first trimester. And oral fluconazole has potential teratogenic risks. Metronidazole treats BV and trichomonas. This is a fungal infection. Doxycycline is contraindicated in pregnancy. Pregnant with yeast, use topical azoles safely. A 30-year-old woman with a family history of breast and ovarian cancer tests positive for BRCA1 mutation. What screening recommendation is appropriate? Annual mammography starting at age 50. Annual MRI and mammography starting at age 25 and 30. No screening needed until symptoms develop. An annual pap smear. So if this lady has a strong family history of ovarian and ovarian cancer positive for BRCA, we should be very progressive with screening starting earlier at age of 25 to 30 with the annual with annual MRI and mammography. So because BRCA carries risk earlier and more intense screening includes the MRI. Routine screening starts later for average risk women. Delayed screening misses early diagnosis. Pap smear screens for cervical cancer, which is unrelated here. So BRCA mutation means early, aggressive screening. Any patient presents with a BRCA1 mutation positive, we should be very progressive with our screening to include MRI and mammography at the age 25 to 30. A 52-year-old woman has a breast mass with pure orange and axillary lymphadenopathy. Which pathophysiological process explains the skin changes? Tumor invasion of the skin causing ulceration, lymphatic obstruction, infectious causing cellulitis, hormonal changes causing skin retraction. Well, with pure orange and axillary lymphadenopathy, we know that is due to the lymphatic obstruction causing edema and skin thickening. This occurs from lymphatic blockage leading to edema and skin dimpling. Ulceration is a later sign, not present here. Cellulitis has redness and tenderness, not dimpling, and hormones don't cause pure orange. I hope I'm pronouncing that correct. Pure orange. Very, very French word. Kind of cool. Uh, Blocked lymphatic causes orange peel skin. And the last question in this video, guys. 45-year-old woman has a visible exophytic cervical mass and a biopsy confirms invasive squamous cell carcinoma. Imaging shows pelvic lymph node involvement without distant metastases. What is the preferred treatment? Simple hysterectomy alone, chemo, radiation with cisplatin, radiation only, and observation. Well, she presents with advanced disease with nodal involvement. So she has a cervical mass, and biopsy confirms invasive squamous cell carcinoma. Imaging shows pelvic lymph node involvement. So we should do chemotherapy and cisplatin. Locally advanced disease with nodal involvement is treated with combined chemotherapy and radiation. So instead of cisplatin, they could have said just, chemo and radiation. That would be the correct answer as well. So surgery alone is insufficient for advanced disease. Radiation alone less effective without chemotherapy, and observation is inappropriate. So nodes involved, chemo plus radiation. In any stem, if they say the patient has cancer and the biopsy shows that lymph nodes are involved, that patient needs chemo and radiation. All right, guys, that brings us to the end of the video one. I will see you guys in the next video. Please leave a comment down. Let me know what school you're coming from and what else you would like to see and how I can improve this video. Good luck.